Hi, I'm Matt Sansing with Disabled American Veterans, and welcome to the first ever Independent Budget Podcast. For nearly 40 years, the Veterans of Foreign Wars, Paralyzed Veterans of America, and DAV have worked together to provide budget recommendations for the Department of Veterans Affairs. And I'm joined today by all of the independent budget partners. Here we have Pat Murray, National Legislative Service Director for the VFW, Joy Ilham, National Legislative Director for DAV, and Heather Ainsley, Chief Policy Officer for the PVA. Thank you so much for being with me today. Heather, I want to start with you here. What is the independent budget and what's the purpose?
So thank you for that question. It's a good place to start, right? So DAV, PVA, and VFW have been working together for nearly 4 decades to produce a comprehensive budget and policy recommendation document on what impacts our veterans through this construct called the independent budget. And so our recommendations reflect what is our best estimate of the funding that VA is going to actually need to meet veterans' demands for the department's services and benefits. And then each of our organizations works together to play a role in authoring and collaborating on the development of those recommendations that then we put out each year, hoping to guide the conversation about where VA's budget will go, which is sometimes a little different than what VA's budget request actually looks like, because we're looking at what do they actually need to provide the services that our members need.
Absolutely. It's a forward look, as you say.
Exactly.
And I want to get into all the recommendations, but first we got to talk about last year's budget seesaw. So in the summer, VA said there was going to have a $15 billion budget shortfall, and of that, including compensation, disability checks. Disability checks would not have gone out on October 1st if Congress didn't appropriate $3 billion in a stopgap measure. How can this happen?
I think that's the question everybody's asking right now, Congress and VSOs included, and veterans, their families, survivors, caregivers. We acted when we saw that there was a need. When we heard that there was a shortfall in the VA's benefits budget, we got together, Congress got together, gave the VA extra money. They didn't end up needing it. I guess we'll say that's good.
Yeah.
And the money is still there waiting for veterans when they do need it. On the VHA side, the numbers have changed. First we heard there was $12 billion shortfall. Now it's $6.6 billion shortfall. And unfortunately, all of this has come together, I think, with a skeptical Congress in terms of what does VA actually need. Understanding that many of us do believe that there is a shortfall, and what that number might be today, I think is maybe an open question.
Absolutely. I think having said that we need funding and then saying we don't need it does not instill confidence for veterans or appropriators or Congress people anywhere.
Especially when we're talking about billions of dollars.
Yeah, the taxpayer dollars.
Exactly.
And we're looking from the perspective of what's happening on the ground, what we're hearing from our members. And PVA has commented often about concerns about specialized care for paralyzed and spinal cord injured veterans. And that's absolutely critical. We can't, with healthcare budgets, these are the lives of veterans that can be at risk when there's a shortfall. A delay in getting, the number right or not getting it right can really impact the health and well-being of our nation's veterans, especially those service disabled and catastrophically disabled.
And that's really important because, for some folks may be able to go and go to another primary care appointment, maybe out in the community or somewhere else that they can access care. There are certain populations of veterans, like the folks that Heather represents, spinal cord injury folks. Those services really aren't available readily out in the community. So it's important that VA gets this right, because that particular group of veterans can't go elsewhere. So that's why that is important, that we're accurate the first time, responsible with the money that is appropriated and given to VA, but that they're also not out here crying wolf, saying that they've got a shortfall, but then they don't, because it is very natural when they're given 4 times to double check, triple check, quadruple check, and they still get it wrong, to then come and say, but we're still short. It is very natural to get skeptical about that. So
that dog don't hunt, as my grandpa would say. Exactly. But despite these budgetary challenges, shall we say, Heather, how dire is the need for a properly resourced VA?
So, It's really the difference for some people of whether or not, as we said, they get the health care that they need. They have a monthly compensation check that they're depending on, maybe a survivor benefit, maybe education benefits. This is the difference for many people between having the health that they need and want, having the financial resources they need and want. And VA really can't afford to get this wrong. Congress can't afford to get this wrong. We've seen on the healthcare side, the number of appointments has increased significantly. We have nearly 800,000 veterans who've enrolled in VA care over the 2-year period. So we have more veterans coming into VA, but we also have an aging veteran population that needs more resources in terms of not only acute care, but also long-term care that many folks need as they age. So it really is one of those things that if the VA isn't properly resourced, it is actually an individual that feels that pain. It's not just some government program that somebody really can't name. No, this is a specific person's life that can be impacted by just something as simple as the VA not properly having the money it needs to do the health care that it needs to make sure that somebody's compensation check arrives when it's supposed to. And that's why this is so important.
And as you mentioned, the 800,000 veterans who have enrolled was a 37% increase over the previous 2 years. So what are some of the other contributing factors for more robust services?
I think Heather mentioned, long-term care is probably one of the things that we've been talking about for several budget cycles now. We know we have this significantly aging veteran population, 75-year-olds, 85-year-olds, and the healthcare needs increase and they also change when you age, especially the population that's using VA. For example, service-disabled veterans are high users of the VA healthcare system. We've had 2 decades of war. We have veterans that need, specialized care because they've had a traumatic brain injury, severe, PTSD that they're dealing with, and other consequences of health-related serious wounds. So for long-term care, we want a comprehensive set of services to match their needs, and we need VA to be nimble. It has to project what it's going to need, what is the demand for services. And as more veterans come into the system, we really need to look at that, that impact, because we want to make sure that all veterans who need care are going to get the care they need and when they need it. And the access and timeliness of that care is critical. If it's delayed, that's a problem. Everybody knows if you're dealing with, an aging parent or a veteran that's really in need of home health services, or you need to have them in a more clinical setting, like one of the community living centers for VA. So again, it is difficult, I'm sure, for VA to sort of anticipate and look at all of these different factors, but that's what's expected of them with regard to the budget.
And for veterans to get this care, the VA must be staffed. So how do staffing shortages impact the quality of care, especially for those with more specialized needs? You touched on it a little bit earlier.
I mean, I can instantly just say that one of the basic needs is if you can have beds, and if you don't have the staff to staff those beds, then those beds close. And that's what we're seeing with some specialty care is that they could accept veterans, not that there's no room at the inn, but there's nobody there to help you with the proper staffing. So those are just some of the basic things that we see. It can also be things like higher wait times for assistance. If you think about folks with spinal cord injury, or diseases like ALS, they may not be able to do the things that many of us take for granted, like feed themselves, and now have to maybe wait longer in order to get fed because there are fewer people trying to help more veterans, just get through something as basic as eating. So, it can have a really high level impact from delayed appointments to not even being able to get in to just basic stuff once you're in a hospital setting, how quickly you're able to get those basic needs met.
Yeah. In staffing, we've heard about, the concerns over freezing staffing levels or hiring staff. It just seems the demand for healthcare all over the country is high, which includes in VA. And knowing the veteran population as we do, they have exceptionally, chronic health issues that are complex health issues. They require a high level of care and coordination of their care. And the staffing, that does a lot of those care coordination pieces and helps with that is, that's an essential part of it. And I think, too, we were a bit confused this last year about, we had hiring sprints and then we had a hiring pause and it went back and forth. And we were questioning VA. And we will have to continue to do so to make sure the right staffing levels are there to meet demand.
Absolutely. And that demand is reflected in increased medical appointments, right? I think in the independent budget, it says it's a 6% increase, which is the most appointments VA has ever had. Where do these medical appointments come from, and how can VA meet that demand?
So one of the things that, as they touched on, right, the aging veteran population, as you get a little bit older, some of your more chronic ailments continue to get worse, get more pressing. But also, there are more post-9/11 veterans enrolling in VA as well, in numbers that are higher than, percentage-wise of previous generations. It was a really interesting visual that VA put out, I want to say this fall, about what the effects of like body armor and your Kevlar and your water and your magazines do to a human body, right? And it was like a almost an X-ray vision of a human, and the compression that happens at the joints when you start adding 10 pounds, 20 pounds, 60 pounds onto someone, not just when you're, in Iraq or Afghanistan, but when you're training that way as well. You're starting that in boot camp now. You train like you fight. So these problems that, previous generations may not have had, now the younger folks are coming in with those, with already difficult physical ailments. Those are not going to get better with age. And so, we'll talk about benefits enrollment here shortly, but the average veteran who was applying for benefits 20 years ago may have only applied for 2 or 3 different conditions. Now they're showing up with 8, right? So that increase is leading to more things that, Uncle Sam did to our bodies that, due to service, and the healthcare may increase with that. So it's not just the aging population is going to need more. The younger population is coming in with more chronic conditions. So we know that this is not something that's going to magically get better, but we have to stay on top of this because, the men and women who wore the uniform have earned this care and benefits.
Absolutely.
And mental health is one area, suicide prevention and mental health is on the top of everyone's mind, especially, the IB, VSOs, and Congress. This is a huge topic that we continue to hear about, and the frustration that we can't see and realize a significant reduction in suicide, despite all of the resources that have been put forth, despite all of the programming. But yet we continue to hear there's a lack of mental health providers, we know, both in the community and in VA. The specialized services that VA trains their providers in terms of evidence-based treatments for treating PTSD, for depression, and other conditions related to, especially wartime service, substance use disorder, and other treatments that veterans really require. All of these things we're seeing increased demand, increased number of people that are reaching out to the crisis line, increased number of people who are trying to get into these specialized programs who have a substance use disorder or co-occurring PTSD and substance use disorder. So all of these things keep compounding. And again, after 2 decades of war, you start to see these things realized, as people age, how they're dealing with their healthcare issues and chronic conditions that can have chronic pain issues, serious mental health issues. And we want to make sure that you get that timely access, because veterans have told us, when I say I want to go for care, I don't want to wait 6 weeks. That's too long for me to get into one of these specialized programs. So we have to try to really look at the budget, meeting those expectations of veterans.
I'm glad you brought up the mental health part, and the Veterans Crisis Line did see a 12% increase over year increase. again, talking about that need. And so far, we've talked about healthcare being in VA facilities within the VA medical centers and whatnot. But let's talk about community care here. When does that come into play when talking about the VA budget? This is up for discussion for anyone.
Community care is a vital component of VA care. It's essentially designed to be kind of like a pressure relief valve. Because VA cannot provide 100% of the care to 100% of veterans 100% of the time. Right? There are people all across this country who are not within hours of a VA facility that need to go to the community. There are certain specialties that VA just doesn't offer these services. So, we need to lean on, our community care providers, but make sure that the system works. There are certain times, if you look at the budget, the community care budget has increased exponentially. A lot of that, if you look at it, is what the VFW is kind of referring to as uncoordinated community care, which is like emergency room visits. Right? If you're enrolled in VA, you slip and break your wrist, you're shoveling snow, you hurt yourself, you can go to, an urgent care. And if it's within VA's network, you can get that reimbursed. But that's uncoordinated through VA. That number is shot up through the roof from a 2020 court decision that said VA had to repay that. So that's a big component of the added cost for VA community care. But also there's a lot of drive time. There are folks in New Hampshire. Every single veteran in the state of New Hampshire is automatically eligible for VA community care because there is not a VA hospital in that state. So an entire state's population of veterans automatically eligible to, go to the community. Now, our veterans in New Hampshire, at least the VFW, will tell you they want you to build a VA clinic near them, so they don't have to do some of that stuff. But where it's needed, we must do it, and we got to make sure it works right. Because whether it's VA direct care or VA community care, if a veteran does not receive care that they're satisfied with, that will erode their trust in the system. That may lead to them not using a benefit or, a service that they've earned. We don't want that. We want it to work right the first time so that when people do have to lean on that and rely on that, it's there for them. Just the same as VA direct care. Our folks have repeatedly told us that, care at VA facilities is preferable, but there are folks that just can't use that. Our veterans in Montana, for example, are 3 hours away from the nearest, VA community clinic. So they have to go in the community. So places like that, we got to make it work. That's the biggest thing that we're leaning on. It's not necessarily more community care. We're not necessarily saying expand it, but where we use it, it has to be good. So it's not a quantity, it's a quality thing. That's what we want to make sure is right.
Go ahead. I was going to say, in terms of budget, community care, something people forget is that a lot of the long-term care VA provides is considered community care. So if you're talking about contracting out to nursing homes, home health agencies, things that VA doesn't provide, they never provided in-house. They work with the community, always have, is part of community care. So I think that, understanding that it's things like, what Pat talked about with maybe my, primary care isn't nearby and I'm going to go into the community, but it could also be things that maybe you have a veteran who gets all their care with VA, but they have a home, they have home care that is through the community because VA doesn't provide that type of service. So it's more complex sometimes than people, I think it is in terms of what's community, what's VA. And that's why we really try to think of, VA being this coordinator of care, VA being the one that is helping veterans get the care they need. And sometimes that's going to mean in the community.
Well, one thing with the independent budget organizations that we've really looked at is this inflection point in where we are with community care. And it isn't just community services, but the impact of not, having enough care or so much care going out into the community where there's an impact on VA's direct healthcare system. So we just want Congress and everyone to be mindful. VA system is really unique. It does provide unique services that you're not going to get anywhere else. High expertise in, war-related injuries and illnesses for veterans. So it's critical that, VA research is not impacted, which is veteran-focused research. The fourth mission where VA really acts as a backup to the nation, and we saw how important that was during COVID. There are a number of things that VA does, the training of our medical providers, which benefit all Americans. So we just want to be mindful and look at the big picture across the board as this community care period, where we're really trying to shore up, fix what's not working right for veterans. Because at the bottom line is that this system is for veterans. It should be about them. They should be at the center of the care.
Absolutely. And there was so much there, but I'm really interested in these New Hampshire veterans who all have automatic access or this right that they can use for community care. I think the point of this is if I wanted to spell it out, if you're a veteran in Sparks, Nevada, and you need a neurosurgeon, you shouldn't have to drive 7 hours to Las Vegas when there's one half an hour down the road, right? I think having those access standards, if I'm remembering back to 2018 with the VA Mission Act, that was a huge part of the negotiation of what we're talking about here. So let's talk about infrastructure now. Pat, where does the VA stand when it comes to their infrastructure?
They're doing horribly. The backlog, what's commonly known as the SCIP list, Strategic Capital Infrastructure Plan, has ballooned over the years. Many VA buildings, hospitals, clinics, things like that are decades old. Within the past, 5-10 years, the list was $65 billion worth of backlogged work, $80 billion, $90 billion, $110 billion, up to $130 billion.
You're recognizing a pattern here.
Yep. Of deferred maintenance, of deferred projects. And it's gone up exponentially, but VA's funding for it, and this is across administrations, across Congresses, has been looking to kind of nibble away at that. There's $130 billion worth of work that needs to get done right now, and they're throwing $2 to $3 billion a year at it. We will never get that done. We need modern, safe, accessible buildings for not just, the folks that work there, but the patients that come in and use those services. VFW members from around the country have told us, and I'm sure many of yours have done the same, that they want, these services closer, more accessible to them. But that may not mean building a VA hospital in every single town, right? That's not sustainable. That may also be an outdated model of healthcare delivery. But, whether it's leasing medical facilities, whether it's building clinics, whether it is building a major medical hospital, that needs to get done. Otherwise, some of these buildings are going to continue to literally fall apart. There is billions of dollars of maintenance, small or minor construction, which is smaller projects under 10 million, and major construction in terms of a big national cemetery or a major hospital. That needs to be prioritized. If we continue to nibble away at this project, we're going to see the backlog list continue to grow, and projects are going to, eke out one by one by one by one. That's not enough. And our veterans deserve more. Even as we talked about, we're not here necessarily to advocate for the workers of VA. It's who they work for, which is the veterans. But they need to be able to work in a safe, modern facility.
Yeah. This has been the most frustrating issue, I think we would all say. We've, talked about it since the beginning of the IB. And again, the infrastructure just continues to age. The delivery of healthcare is different, how it's delivered. And these facilities need to be replaced and several attempts over several administrations have tried with the CARES, the Capital Asset Realignment proposal, as well as the latest sort of air proposal that was in the Mission Act, I believe, right? And they've failed, and that's really failing our veterans. Congress has got to take this issue up and make a decision on what they want to do. And the decision can't be, we're just going to continue to ignore this issue and not address it in a way that's meaningful to look at this infrastructure and what it means, because direct healthcare services and clinical staffing, the infrastructure and the clinical staffing are the two things that are key to making sure VA can provide the most care and be the coordinator of care from those facilities. The more that you let that go, the more care you have to provide in the community if these facilities aren't habitable anymore. And we've seen some of the research facilities and others that have been closed, and they're not safe, or seismic issues that exist, and that just goes on year after year after year. So we really hope, and we're really going to be pressing Congress on this issue, and we hope that they'll address it this year.
Yeah.
And right now their plan is kick the can down the road, and that plan stinks.
Yeah.
But they've been doing that now for a couple decades.
Many dents in the can.
Right. And what we've seen, just an example of how, delivery of care has changed. If the spinal cord injury centers are a perfect place for that. We used to have 4-person rooms. Supposed to be good for rehabilitation. You're not alone, stick in a room by yourself. Well, the way in which care is delivered has changed. Oh, and by the way, throw in an infectious disease pandemic like COVID. And now suddenly you have people who get an infectious disease. You have to isolate them. If you've got a 4-person room, well, now you got a 1-person room because we can't have other people in there. And so we have, then we have fewer beds. Then we have fewer opportunities to serve folks. So the infrastructure, as Joy was saying, really can inhibit how many people VA can serve as the models of care change. And quite frankly, just the environment of care. I know the average age of a spinal cord injury center is almost 40 years old. That's doesn't inspire confidence. Sometimes you walk in, you're like, gosh, this thing could be remodeled, And so we do want to make sure that that's why the IB put in such a significant increase for infrastructure, because it's one of those things like we're never going to get there unless we actually put the pedal to the metal and start trying to get to the end game here. And if the buildings fall down, there is no VA direct care. I mean, there's no place to provide that.
And Congress has been frustrated. Pat's talked about it a number of times, where VA is given funds and then these cost overruns occur, and they're not managing the funds properly in terms of these projects. And that's another key aspect we really hope this administration will, focus on, because these, we don't want to see dollars wasted. We know that it's a big investment, but our veterans are worth it and they deserve it.
They really do. And if we look at some of the waste, I think the Denver hospital project was maybe the biggest example where they were, I don't know the exact number, how many tens, hundreds of millions they were over budget and years behind schedule, that, they, even when given what's seemingly the appropriate funding, they screwed the pooch on it, right? They did not actually, build that hospital effectively. But, we have to be careful about this stuff. We can't continue to underfund this, underprioritize this. There was a part of the Mission Act, Joy mentioned the AIR Act, which is the Asset Infrastructure Realignment Act, that proposed all kinds of changes to right-size VA to where the veterans are. The VA system was really expanded, post-Vietnam, but the veteran population is different today than it was in the 70s. So, where veterans live is shifting, and the AIR Act and the market assessments were meant to kind of realign and, propose VA assets where veterans are. That bill got squashed last Congress or the one before? 118th Congress. It had all the potentials to right-size VA for where we need it. We want to see something like that revisited so that we can point to where we're going to not just throw $130 billion at this problem, but where to target it, where to spend it smartly. Not just continue building major hospitals in places that may not need it. Nothing where, it used to be we want to see resources put where veterans are. It's a smart way to spend, so we're not wastefully spending. But that's an important thing we want to revisit, is that AIR Act and those market assessments, so we can focus the finite resources we have towards where they're needed.
So if it is creating this backlog of maintenance projects here, why doesn't the VA include it in its budget request?
It is, but
at lower rates.
Yeah, as we heard,
need it.
Former Secretary Dennis McDonough at, I believe it was a House hearing, said, they had to make tough calls to, meet a budget kind of target. That was in reference to some of the infrastructure low requests. The need is there. If you have a bill, you get a credit card bill and it says it's $100 and you keep putting $1 towards it, $1 towards it, $1 towards it, eventually that's going to continue to grow. What our ask is like a 10-year plan to tackle this project. So that may mean $12 billion a year to eventually get there. And that's what we want to see. We've also heard from other major healthcare networks like Kaiser Permanente that spends 3% of their operating budget annually on their building upgrades and infrastructure, things like that. VA spends 1%.
Wow.
So, the private sector, who we often look at as, the folks that know how to get it done, know how to work efficiently because they're worried about a bottom line. They also want to continue working, keeping their model going. They're spending 3%. So, we're asking for VA to spend more than 1% of their overall budget on the buildings and the bones, the structure, the literal foundation of healthcare.
Brick and mortar places where veterans walk into. Yeah. So what's needed to overcome these VA infrastructure challenges? We've talked a little bit about it, but what else can be done?
They have to hire some more people to oversee more of these projects. They need to fund it at appropriate levels. They need to stop kind of trying to nickel and dime this problem, because it's waiting and delaying and deferring is not going to make the problem go away. It's only going to compound. It's going to get more expensive. We've seen that with infrastructure across America, right? Look at our roads and bridges and things like that. It's a problem that we all collectively will worry about tomorrow. We can't do that with healthcare.
And one key thing Pat said is people with expertise to manage these projects appropriately are going to be key, because these precious dollars cannot be wasted, not $1. And they've got to have the people in there. VA just hasn't had the expertise in this. They haven't built, over enough facilities to really be able to have a good handle on how to manage these big projects, to make sure they don't get cost overruns and that they're done in a timely way, not taking over a decade to make happen.
And we do need more people, because if you just wrote them a check for $13 billion, VA would not use 10 of it.
It could
right? Because they don't have the people to also build that capacity that's needed. So it's kind of a two-pronged thing. We got to give them the money, but we also got to give them the people to manage that money, to oversee that money, to implement those projects properly, so that we don't have hundreds of billions of dollars and years delayed on a single project when, we need 30 to be going all at once. Never mind, screwing up one.
Yeah. And we hope it's a priority for all members of Congress, because there are facilities in most states, and they fight for those facilities, so we want to fight for that modernization effort that's been underway. There's a number of things, but infrastructure is a key part of that modernization.